Welcome to your Week 4 lecture. You should have read these 3 chapters by now. This week we'll do cardiovascular system pathophysiology. Let's get started. In Week 4, we will look at how things can go wrong with the cardiovascular system. As you recall from AP2, the cardiovascular system is one of 2 of the transportation systems of the body, with the other being the lymphatic system. Veins bring deoxygenated blood back to the heart, and the heart sends blood to the pulmonary circulation to be oxygenated, then distributes the oxygenated blood out to the rest of the body. We will discuss the arteries first, and then the heart. What are arteries? They are muscular walled blood vessels. They move oxygenated blood away from the heart, except the pulmonary artery, which moves deoxygenated blood away from the heart. Arteries can be compliant, meaning they can stretch, or they can have constriction, which can increase the blood pressure. Arteriosclerosis is hardening of the arteries and narrowing of their lumens. Atherosclerosis is plaque buildup on the arterial walls that can lead to blockages. Here is the arterial anatomy. The inner lining of arteries is called the tunica intima and has the endothelial cells. If these are damaged, then this can lead to atherosclerosis. The tunica media contains the smooth muscle and has alpha and beta receptors which regulate blood flow. Alpha receptors cause vasoconstriction and beta causes vasodilation. This is also known as constriction and relaxation. The outer covering of the adventitia is composed of connective tissue. The endothelium is essential to our health and well-being. It provides a semi-permeable membrane for fluid protection and allows for the chemotaxis of cells, like the neutrophils, to move into the tissues when needed. The endothelium will release certain chemicals for different functions. Nitric oxide will cause the vessel to dilate, and endothelium results in constriction of the vessel. Angiogenesis is the formation of new arteries and can be influenced by VEGF. Diuresis is a fluid loss, and C-type natriuretic peptide influences this. Prostacyclin will inhibit clot formation, and thromboxane A2 stimulates it. Again, we have pointed out countless times in this course, endothelial injury is the start of arteriosclerosis and atherosclerosis. The injury of endothelium will attract white blood cells and cause inflammation, deposition of foam cells and lipids. Nitric oxide is inhibited, and vasoconstriction happens along with plaque formation. This causes a narrow artery prone to blockages. Blood flow is basically cardiac output. Cardiac output is how much blood the heart can put out in one cycle or beat. We can measure the blood pressure and then obtain the cardiac output or peripheral vascular resistance depending on what other pieces of information we already have. For the exam, you should be able to algebraically manipulate this formula and give the missing piece of information or show how you can do this. With blood pressure, the top number is called the systolic and the bottom is the diastolic. We monitor the blood pressure as high blood pressure or hypertension over a long period of time will cause endothelial injury and can lead to aneurysm formation. Systole represents cardiac contraction while diastole represents cardiac relaxation. Pulse pressure is the difference between these two measurements. Think of a large flowing river. It may not make much noise as it flows along at a steady pace toward another river or the sea. Just like this river, blood flowing slowly in a large space will not make very much noise. This is why when you listen to a healthy carotid artery, you will not hear much noise. This river has a smaller diameter and even has rocks and other debris in the way of the water flow. It is noisy and much more turbulent than the first river. When blood reaches a point of a narrower diameter and less space, then the flow will increase in speed and hit the sides of the arterial wall like the water does these rocks, creating noise. This blood will be fast until the narrow passage becomes narrower with buildup of more debris and eventually will go silent with an occlusion. This is why 100% occluded carotid arteries lack a bruit and 95% will still have one. The smaller the diameter of the arterial opening, the faster the blood will flow. Vasoconstriction will raise the blood pressure. Vasodilation lowers blood pressure. The longer an artery is under stress from hypertension, the greater chance of aneurysm formation. Stroke volume is the amount of blood ejected by the heart after each beat. The preload is the filling pressure coming into the heart. The afterload is the amount of peripheral vascular resistance of the heart must overcome to eject the stroke volume. Contractility is the force of the contraction or the amount the heart will contract on each beat. This can be driven by nerve stimulation or from overall health of the heart muscle. All these aspects are relative, meaning they can affect one another. If you increase peripheral vascular resistance, you will increase afterload and decrease cardiac output. Increase cardiac output and you can increase preload as more blood volume begins to back up. Decrease heart rate and you can decrease the cardiac output. Think of it in terms of this water hand pump. This woman's number of pumps is the rate, and the force she uses on each pump as the contractility. The preload is the volume of water in the well, and the afterload is virtually non-existent here as the gravity is assisting at the point the water exits. But the water does have to be pumped against gravity until it reaches the top. Here is a table showing how stroke volume can be affected by preload, contractility, and afterload. Increased afterload caused decreased stroke volume, and decreased afterload causes increased stroke volume. You can study this table to help you learn the relationships between these principles. We will revisit this again when we get to the heart. Blood pressure is regulated by three principal mechanisms. The baroreceptors located in the carotid arteries will help regulate the blood pressure as they are monitoring the blood flow to the brain. These receptors will send signals to the medulla oblongata and the pons, which can affect heart rate, contractility, and vasoconstriction. Next is the all too familiar RAAS, or the renin-angiotensin-aldosterone system, which is stimulated by a loss of blood pressure at the renal artery. Angiotensin is a very potent vasoconstrictor, and aldosterone will increase blood volume. Both will increase blood pressure when it is low at the renal artery. This can be a good thing as it helps us during shock, but a bad thing if there is renal artery stenosis, and this can cause secondary hypertension. Lastly, ADH, or antidiuretic hormone, is released when blood pressure is low to increase blood volume. Both aldosterone and ADH increase blood volume, but in different ways. ADH does it by water reabsorption directly at the kidneys, while aldosterone does it by sodium reabsorption, and the water will follow by osmosis. Hyperglycemia from diabetes, tobacco, smoking, hypertension, hyperlipidemia, obesity, and just getting old all can lead to endothelial injury. Endothelial injury then can lead to atherosclerosis after prolonged inflammation, lipid deposition, vasoconstriction, and thrombosis events. We again emphasize that endothelial injury initiates atherosclerosis. This is caused by free radicals, homocysteine, glucose, hypertension, and other elements. Once this happens, there is inflammation, fat, and foam cell deposition. Plaques begin to build up, and the vasodilation ability of nitric oxide, or NO, diminishes. Now the artery becomes calcified, and the lumen becomes narrower and prone to blockages by clots or ruptured plaques. We can screen patients for atherosclerosis using HSCRP, or highly sensitive C-reactive protein. The regular CRP will be negative if they are otherwise healthy without infection or inflammatory diseases. But this more sensitive test will show us the subtle inflammation that occurs in atherosclerosis. Atherosclerosis is caused by endothelial injury. Do you recall what causes endothelial injury from the previous slides? Atherosclerosis can lead to angina, myocardial infarction, cerebrovascular accidents, peripheral arterial disease, renal artery stenosis, and many other conditions. Hypertension leads to atherosclerosis. It is a silent killer, as few symptoms will present themselves over the years until major disease is obtained. Most people with hypertension do not even know they have it. Most of these patients have primary hypertension, which means it is due to genetic cause or unknown cause. Secondary hypertension is from a known cause, like renal artery stenosis, pheochromocytoma, or Cushing's disease. About 1/3 of adults in the U.S. will suffer from hypertension. Risk factors include age, ethnicity, obesity, family history, diabetes mellitus, tobacco use, stress, alcohol use, untreated hypertension. All can lead to heart failure from left ventricular hypertrophy, aneurysms, and strokes. Left ventricular hypertrophy comes from increased afterload to the left ventricle from increased peripheral vascular resistance. Like a weightlifter, the muscle will enlarge in size as it has to work harder and harder. The muscle will get bigger and bigger as it pushes against more and more peripheral vascular resistance until the chamber of the heart is too small to effectively feed the heart, and then the heart muscle will atrophy, and you will end up with heart failure. Orthostatic hypotension is where the blood pressure drops upon standing, causing symptoms of dizziness or even syncope. This could be due to over-medication, GI bleeding, or loss of large blood volume from surgery or trauma. It could be due to autonomic nervous system dysfunction too. You can tell based upon how the heart rate reacts to the drop in blood pressure as seen here. The heart rate should increase with a drop in blood pressure as the body tries to compensate to return to homeostasis. If this does not happen or is too slow to respond, then the issue may be more neurologic or due to Parkinson's disease or perhaps Lewy body dementia. Cholesterol comes from fatty foods we eat, but we also make our own cholesterol as we are animals. We make cholesterol from carbohydrates. Triglycerides are fats in general. LDL and HDL cholesterol are the bad and good cholesterols, respectively. LDL is considered bad as it deposits plaque onto arterial walls, and HDL is good as it reverses this process and helps to excrete cholesterol from the body. Cardiovascular disease is associated with high LDL and low HDL. Risk factors for hyperlipidemia include genetics, diabetes mellitus, obesity, hypothyroidism, sedentary lifestyle, diet and high saturated fats, and long-term medications like steroids. Fat can deposit on the surface of the skin or just under the skin in some cases if the cholesterol and/or triglyceride levels are very high. Labs include a cholesterol or lipid panel. Look at the LDL and HDL levels. Maybe the HDL is high enough to rectify the LDL. What is the patient's HSCRP or highly sensitive C-reactive protein level? This will measure the amount of atherosclerosis they already have. Check homocysteine levels too, as this can lead to atherosclerosis from endothelial damage. Remember, for diseases like hypertension and hyperlipidemia, begin with diet and exercise or lifestyle changes. This will build trust between you and your patient as well as see what they can accomplish on their own. Diets to lower cholesterol involve good oils, fats, and lower carbohydrates. Diets to lower hypertension need lower sodium levels. Only after changes in lifestyle and diet will you institute medications. Patients can build up many medications as these diseases tend to run together. Hypertension, hyperlipidemia, and type 2 diabetes, sometimes hypothyroidism and others. Treat hyperlipidemia with statins, which are lipid-lowering agents. Hypertension needs treatment with medications that lower heart rate, lower blood volume, and cause vasodilation, as all these will decrease blood pressure. ACE inhibitors will lower the RAAS if this is the primary reason for the hypertension. We can screen for atherosclerosis of the heart with a CT scan of the coronary arteries. That is low in power, getting a calcium score. Coronary artery atherosclerosis is also evaluated using coronary artery angiography. This is done with the catheterization of the femoral artery going superior to the coronaries, then injecting dye and watching on a fluoroscope. During a coronary catheterization, you can do angioplasty or ballooning opening and blockage, then place a stent to keep it open. Stents may be drug-eluting, meaning it has medication on it to prevent clot formation. The next slide shows a surgery, so viewer discretion ahead. CABG or coronary artery bypass grafting is done when there is 2 or more blockages that are not amenable to stenting and angioplasty. It is an open heart surgery using veins from the legs. You can make new connections and bypass the blocked arteries. Peripheral arterial disease is asymptomatic at first until about 70% blockages. The patient will experience intermittent claudication or pain when standing or walking. They will frequently sit or lay down on the bed and rub their legs for comfort. Leg pain with prolonged walking or standing again is known as claudication. To diagnose peripheral arterial disease, you need to do a history and physical examination. They will complain of claudication and have history of conditions like diabetes type 2, hypertension, hyperlipidemia, etc. Exam will show pale extremities. You may see bluish color to the legs and toes. Hemosiderin deposits may be seen in the skin. The pulses will be diminished and the capillary refill time will be much longer than expected. Next, do an ankle brachial index, as it is a cheap and effective screening test. Screening tests are inexpensive and are useful to figure out if you need a more expensive test. A score less than 1 is positive for ankle brachial index test. Arterial ultrasound is the next if the index is positive, and then angiography needs to be scheduled. A CT scan may be done prior depending on the issues. Again, we start with lifestyle modification to treat peripheral arterial disease. This will build trust between you and your patient as well as see what they can accomplish on their own. They may need medications like Pleatal or angioplasty and stenting or even a bypass graft. Aneurysm can form from atherosclerosis, as we have discussed before. Uncontrolled hypertension can also lead to weakened arterial walls, leading to aneurysms. Abdominal aneurysms, as well as the berry aneurysms we have talked about in previous chapters, can form and rupture, causing bleeding and death. Screening for a AAA is done with an ultrasound scan of the abdomen. This is cheap and non-invasive, or will not cause any harm to the patient. The screen would be done in a patient with risk factors for an abdominal aneurysm, like a male over 50, smoking history, hyperlipidemia, hypertension, etc. If positive, then you would get a CT scan of the abdomen with contrast to evaluate for the AAA. This test is more invasive as it uses radiation and IV contrast dye that can hurt the kidneys potentially. AAA may need to be monitored, but also may need surgery. Being male, over 50, smoking, and known atherosclerosis are all risk factors. CT scan would be the next step after an ultrasound, if present, but not very large. It may just need to be watched. But if too large, then it's a surgical urgency or emergency. Pressing on a large AAA that is a pulsatile mass on the abdomen is contraindicated, and you cannot do deep palpation examinations on these patients. Aortic dissection can be very deadly, and the patient can deteriorate rapidly. They will complain of a tearing chest pain and not the pressure pain felt in an MI. They can be younger and a lower risk for a myocardial infarction. Actor John Ritter died from this, unfortunately, as he was treated as an MI patient. It is important to be able to distinguish this patient's presentation from an MI, as this is a surgical emergency. EKG will be normal most of the time, and these patients will have a negative troponin test. Chest x-ray will show a widened mediastinum. CT scan of the thorax with contrast is most diagnostic. Wide pulse pressures may be present, meaning different blood pressures in the arms. These patients will have a tearing chest pain, and they get confused often with patients who are having a myocardial infarction or angina. They will have a widened mediastinum on chest x-ray like the one you see here. Troponin and EKG will be fine, but this is a surgical emergency and the time is of the essence. This is an important patient presentation to know. Vasculitis is inflammation of the arteries, and depending on the size of the artery or arteries involved, this will give you the specific disease or cause. There is large, middle-sized, and small arterial vasculitis. You can also have secondary vasculitis due to another primary disease like lupus, Sjogren's syndromes, or rheumatoid arthritis. Temporal arteritis is an emergency. If you suspect this condition, then you need to obtain an ESR or sedimentation rate in CRP or C-reactive protein and schedule for temporal artery biopsy. If left untreated, the patient may go blind in the eye nearby. Biopsy must be done prior to starting steroids, and if negative, then stop the steroids, and if positive, then continue them. The patient will be older and complain of a temporal headache that can radiate to the scalp. Visual changes in the eye on that side may or may not be present at the start. Takeiso's arteritis is inflammation of the aorta and its branches. The cause is unclear, but this does occur in Asians more than any other ethnic group. They will usually be younger have claudication, decreased pulses, blood pressure loss. ESR and CRP will be elevated. Treatment is steroids. Polyarteritis nodosa occurs in small and medium-sized arteries. It may be associated with viral infections. Again, steroids are the treatment. The legs are frequently involved and have color changes like these. Kawasaki's disease is rare but dangerous and follows a viral infection in a child. The child will have a systemic vasculitis that can lead to a myocardial infarction. They must be monitored closely and may require IV immunoglobulin and aspirin. They have a characteristic rash, and the strawberry tongue finding is common in the presentation. CRP and ESR are elevated. Berger's disease, or thromboangiitis obliterans, is a disease of usually young male smokers. It happens frequently in the toes, but can also involve the fingers. Treatment is to get them to stop smoking and give vasodilators and encourage exercise. Raynaud's disease, or phenomenon, is vasoconstriction of the arterioles of the hand and fingers, usually due to cold exposure. This causes the red, white, and blue color changes you see here. This is usually associated with an autoimmune disease such as lupus, Sjogren's syndrome, or sarcoidosis. Now on to the heart. It is the size of a fist normally and is a miraculous organ that beats from fetal life to the day we die. Just think of all the beats this organ must do without stopping in an average 70 to 75-year lifespan. It sits in a sac called the pericardium, which protects it. It is located in the mediastinum between the lungs. When it is starved for blood with ischemia, that is called angina, which can be stable, meaning it can go away as perfusion is still intact enough to prevent tissue death, or it can be unstable, causing acute coronary syndrome and a myocardial infarction. Remember, ischemia is the lack of blood flow, and infarction is prolonged ischemia with evidence of tissue death and destruction. After the pericardial sac, the layers of the heart from most superficial to deep are the epicardium, myocardium, and endocardium. This should already be familiar to you from AP2. The coronary arteries supply the heart with blood, and there are two main branches, left and right. Here are the coronary arteries. Remember that the heart feeds itself first, meaning the coronary arteries are the first branch off of the aortic arch. The left anterior descending artery, or LAD, is the most important branch, as this branch will cause the loss of the left ventricle if it is occluded. It is known as the widowmaker. Let's review the four chambers of the heart and how blood flows through the heart from AP2. Deoxygenated blood is received from the IVC and SVC, or inferior and superior vena cava, and enters the right atrium. The blood then enters the right ventricle through the tricuspid valve and then to the pulmonary valve via the pulmonary artery via the pulmonary valve. The blood is oxygenated and returns to the heart via the pulmonary vein to the left atrium. This is the only time a vein carries oxygenated blood. The blood leaves the left atrium through the mitral valve and enters the left ventricle. The blood is pumped from the left ventricle to the aorta and passes through the aortic valve and onto the body. What is the purpose of the papillary muscles and the chordae tendineae? They keep the tricuspid and mitral valves closed to prevent regurgitation. If they are damaged, then mitral and tricuspid regurgitation can occur, causing high output heart failure due to an inefficient pump. You can examine the heart sounds using a stethoscope. You can hear the aortic valve on the right of the patient and then the pulmonic valve on the left point called P. And then the E is for the Erb's point, where you can hear the pulmonary valve as well. And the T is the tricuspid valve area. And finally, the lowest area under the left side of the patient is the mitral area, or marked M. You can remember these areas with the mnemonic, a pet monkey. The order of conduction, or the electrical activity of the heart, begins with the SA, or sinoatrial node, which is the pacemaker of the heart. Then it goes to the AV node and the bundle of His, both right and left, to the bundle branches, and then the Purkinje fibers. The atria contract first, then the ventricles will contract. While the atria contract, the ventricles will relax. When the muscles contract, it is called depolarization, and when the muscles relax, it's called repolarization. You will need to know the order of conduction for the exam. Again, reviewing what you have learned in AP2, the cardiac muscles are at rest at first, and then depolarization takes place. Then, once the action potential is reached, repolarization begins to restart the process again. Sodium, potassium, and calcium channels are all involved. At rest, the muscle is at negative 90 millivolts, and at peak, it reaches about positive 20 millivolts. There are refractory periods with muscle contraction where muscle rest must occur before another action potential can start. In the heart, this allows for the rest period so the heart chambers can refill with blood. The refractory period also protects against arrhythmias, which are bad heart rhythms. If the electrical signal is produced by the SA node, atrial, or AV node, then it is known as supraventricular. If the signal is from the bundle of His, bundle branches, or Purkinje fibers, or ventricular muscle, then it is ventricular. Tachyarrhythmias are faster than 100 beats per minute, and bradyarrhythmias are slower than 60 beats per minute. A block is where one of the conduction pathways do not work like they should. An ectopic pacemaker is when the normal pace or normal conduction pathway goes astray, causing the ventricles to beat before the atria. We can measure the conduction of the heart with an electrocardiogram or EKG or ECG. As you recall, the P wave comes first, then the QRS complex, followed by the T wave. This is the normal sinus rhythm. The space between the start of the P wave and the start of the QRS is the PR interval. The ST interval is from the end of the S wave to the end of the T wave. The ST segment is from the end of the S wave to the start of the T wave. Using the RR interval between the two beats, you can estimate the heart rate. Each square of the EKG is in millimeter per millivolt, or 0.04 seconds per 0.1 millivolt. The standard EKG is 12 leads. Think of each lead like an eye that is staring at the heart from a different direction. Here's the normal 12-lead EKG. We can estimate the rate by looking at the first R wave that hits a line, then continuing till we find another R wave close to a line. The first line after the R wave that hits the line is 300, then 150, then 100, 75, 60, and then 50. Here we can estimate this rate between 75 and 100, probably about 85 to 90, as it is a little closer to the 100. The rhythm is normal sinus, as we can clearly see the P wave and the QRS complex along with the T wave. 2, 3, and AVF are the inferior leads, as they are like eyes staring at the bottom and left of the heart, and are very important as they can tell if someone is having a left ventricular MI, which is a very common and deadly MI. Let's correlate the EKG with the cardiac cycle and conduction. The P wave represents atrial depolarization, which is when the atria are contracting and pushing blood into the ventricles. This is atrial systole. Here the tricuspid and mitral valves open. The QRS complex represents ventricular depolarization, and the ventricles are now contracting with the pulmonary and aortic valves open. This is called ventricular systole. The T wave represents ventricular repolarization, or the resting of the ventricles, which is called ventricular diastole. Where do you think the atrial repolarization is occurring on the EKG? At the beginning of the QRS complex, but the electrical activity of the aorta is not strong enough to outshow the ventricular depolarization, as these chambers are much larger, so it is hidden. This is all review from AP2. What happens when a block occurs and the pacemaker SA node is no longer in control? Other pacemakers can take over to keep the heart beating. Depending on how much the SA node is blocked, this will influence the degree of the heart block. At worst, the atria are no longer connected to the ventricles, so they beat independent of one another. Here is normal sinus rhythm. See how the SA node is the pacemaker in every beat. There is no sign of heart block here, no signs of arrhythmia either. The rhythm is regular and equally spaced out. In first degree heart block, the PR interval has increased, and the SA node is beginning to lose control over the ventricles. The conduction to the AV node is slowing down. Now we see here in second degree heart block type 1 that the SA node is losing a beat. See the space between the beats after the third one? We have a P wave without a QRS. Second degree type 2 is similar but with a longer absence of the ventricular beat. Again, we have a P wave without a QRS, but the SA node is still stimulating the ventricular beat most of the time. Third degree heart block or complete heart block is complete dissociation of the SA node as the pacemaker over the ventricular beat. The P wave appears almost anywhere, and so does the QRS. Everyone gets a PVC or premature ventricular contraction every now and then. It makes you feel like your heart skipped a beat. Premature ventricular contractions can occur more regularly in patients with myocardial infarction or recent heart surgery. If they occur more than once, it can be bigeminy, if two together, or trigeminy of three, and so on. Persistent PVCs can cause ventricular tachycardia, which is an emergency. Patients with these changes on telemetry need careful monitoring on telemetry on the cardiac 4. AFib or atrial fibrillation is the most common dysrhythmia. It is an irregular rhythm, meaning it has an unpredictable pattern. P wave are absent as the atria are contracting erratically and look like a bag of worms. If you could view the heart from the outside, this rhythm can become tachyarrhythmias if there is a rapid ventricular response from the atrial fibrillation. Paroxysmal supraventricular tachycardia is a fast heartbeat. Paroxysmal means suddenly. It can come and go in these patients. Many are young who get this, and it can be hereditary. They may need an IV medication to stop it or shock, but these patients are unconscious, so it can be painful to do so. Patients will feel palpitations when they have this rhythm, and they may need a Holter monitoring to catch it if it comes and goes quickly. Electroconduction studies may be needed, and this rhythm responds well to surgical ablation. Ventricular tachycardia, or VT, is a serious problem. This rhythm is not perfusing the body well, and the patients will deteriorate quickly. This is a code situation, and VT or VTAC can become ventricular fibrillation. The P wave is non-existent as the ventricles contract rapidly. This rhythm must be shocked. Most patients go unconscious if this rhythm lasts too long. VFib, or ventricular fibrillation, is deadly and is a code situation. This is the rhythm that must be shocked to correct. All patients with this rhythm will be unconscious. Fibrillation means like a bag of worms or quivering. In asystole, there is little to no electrical activity of the heart. You do not shock this rhythm as they do in the TV hospital dramas. This needs CPR and chest compressions along with IV medications to stimulate heartbeats. Only shock if you get this to a VTAC or VFib to get this into a normal sinus rhythm. So remember, the only time you do defibrillation on a patient would be during an episode of VTAC or VFib, and consider it an SVT if they do not respond to chemical cardioversion. We never shock asystole. A pacemaker may have to be implanted in a patient with a complete heart block or significant episodes of bradycardia. Patients who have had ventricular tachycardia or ventricular fibrillation may benefit from an implanted defibrillator. Patients with biventricular heart failure can benefit from a special pacemaker that helps improve ventricular function. EKG can show us ischemia of the heart as well as infarction, but they look the same, and this is why you cannot discern between the two, and only an EKG must with only an EKG, and you must check the troponin levels of the serum. ST segment elevation MI will have an elevated ST segment. These are also called tombstones, as these patients may die and have higher mortality. There are also myocardial infarctions without ST elevations, but there will be some changes in the patient's normal EKG, particularly in the T waves. Chest pain is the common patient complaint, and we hear the sirens of the fire trucks and ambulances many times a day as they make their way to these patients. Angina is a chronic chest pain. It is stable when it will go away with rest or nitroglycerin. This comes from a blockage that still allows blood flow to the heart but causes pain when the heart rate increases or the coronary artery constricts for some reason. Stable angina can be unstable when it worsens than the usual chest pain is now accompanied by diaphoresis, shortness of breath, nausea, etc. Women in certain ethnic groups may have atypical chest pain like jaw pain or shoulder pain, typically cardiac chest pain. It is left-sided and radiates down the left arm and causes numbness and tingling of the left arm. Stable angina can become unstable or acute coronary syndrome as a ruptured plaque breaks off and travels to a partially blocked area, now making the artery completely blocked, leading to a myocardial infarction. And MI is an infarction, so the ischemia is prolonged, and now there is damage to the heart muscle. We can only tell the difference between angina and an MI by a troponin test, as the EKG looks similar. Risk factors for an MI include age, smoking, diabetes mellitus type 2, hyperlipidemia, metabolic syndrome, hypertension, family history, etc. Usually the patients state that the chest pain is a pressure pain and feels like an elephant sitting on my chest. They will rank the pain about 9 to 10 on a 1 to 10 pain scale. They will use their left hand or left arm to grab their chest. They will touch their left chest as well and rub it. This is called Levin's sign. They may even do this when complaining of other pains like a toothache. You cannot make the pain better by moving or laying down in certain positions. This is not musculoskeletal. It also cannot be worsened by pressing on the chest wall muscle, as again, this is not musculoskeletal. Anginal patients will take nitroglycerin up to 3 times to see if it goes away. And if it does not, then unstable angina is likely. Workup includes a good history and physical examination along with an EKG, blood pressure, serum blood tests like troponin, and other cardiac enzymes and lipid panel. If unsure if the patient has atherosclerosis, then check an HSCRP. Sometimes the workup will be negative for a heart cause, but you can discover underlying coronary blockages that were not causing the current chest pain. Many other medical problems can cause chest pain, including muscle or bone pain, esophageal spasm, and lung pain. If a positive troponin, then the patient will need treatment and will get a coronary angiogram. If a negative troponins, then consider looking at a CT scan of the chest or X-ray. Calcium score CT scans are done as an outpatient. You are looking at for possible risk of future heart problems, and atherosclerosis of the coronary arteries are likely. We do not do CT scan on active heart attacks. Instead, they will get angiography in the cath lab. We can do stress testing, stress echo, myocardial perfusion scanning to see if the patient has angina or vasospasms of the coronary arteries. Could they have a blockage that caused the pain but did not result in an MI? This will also rule out the heart as the chest pain cause in patients with significant risk factors for having an MI in the near future. Outpatients can get a cardiac CT scan to assess calcium scores. Treatment is key in the patient having an MI. They need MONA therapy, including morphine for both pain relief and breathing control, oxygen to save heart muscle, nitrates to vasodilate the coronary arteries, and aspirin to prevent further clot formation. Beta blockers, ACE inhibitors, as well as statins may be added to at discharge or during the stay to protect the heart from further damage, reverse some damage done from damaged heart muscle. Cardiac catheterization is key to saving heart muscle with angioplasty and stenting or CABG if this is not possible. A myocardial infarction is prolonged ischemia that causes damage to heart muscle. This is reflected in the elevated cardiac enzymes we see, especially in the troponin elevations, and this is very specific for the heart muscle. Heart attacks are the leading killers of both men and women, so we must be diligent in helping these patients. If the MI lasts too long, permanent damage is done, and this can lead to heart failure. How deep into the muscle the damage goes and how widespread means the worst outcome. But sometimes the muscle is just stunned and will recover with time. Arrhythmias, like we discussed, can occur as the heart recovers, so the patients need good telemetry monitoring. They may need pacemaker implantation or defibrillators. Again, EKG can only show ischemia. So to be able to tell the difference between angina and an MI, you need the troponin testing of the serum. We will draw these, if not positive yet, in a serial amount. Some MIs are not large and may take time for the troponin levels to rise. Again, the coronary arterial angiography can have treatment, including angioplasty and stent placement to reopen the blocked artery and perfuse the heart muscle. This is crucial to restore perfusion to the heart and must be done quickly as time is heart muscle cost. As we showed you earlier, CABG may be done if stenting is not possible. This will place a new venous graft in the place of the blocked artery. The venous grafts are harvested from the patient's legs. The worst MI complication is death, of course, but there are several others that can be detrimental to the patient. Papillary muscles can die or rupture during an MI. If you do not have working papillary muscles, then they cannot keep the tricuspid and mitral valves closed, and you will end up with regurgitation. If this is bad enough, then you can have backflow of blood and a very inefficient pump, which could lead to heart failure. All of the dysrhythmias we discussed can also be a complication of MI. Heart failure is a complication of MI we see frequently as ischemic cardiomyopathy is the number one cause of left side heart failure. This will cause pulmonary edema, some edema of the legs, difficulty breathing, or laying flat. Left side heart failure can lead to right side heart failure, which can give you pleural effusions, ascites, more pronounced edema. Biventricular failure is a high risk for VTAC and VFib and needs ICD placement, which is an implantable defibrillator. You can have aneurysms of the vessels of the heart post-MI or pericarditis if there is pericardial effusion. This could lead to tamponade or the decreased ability of the heart to contract due to pressure from pericardial effusion. Pericarditis is a symptom of a prior MI, but it can also come from renal failure as these patients get pericardial effusions. Most pericarditis sufferers will have elevated BUN and creatinine, be older individuals, and complain of shortness of breath. They may need pericardial fluid drained from the pericardial sac, if it recurs, then a pericardial window placed to keep the fluid drained. Dreddler Syndrome is a pericarditis that occurs directly due to a prior MI. Pericarditis patients will have JVD or jugular venous distension, hypotension, and muffled heart sounds. Some students get confused by patients with pericarditis or myocarditis. Remember, in pericarditis, the patients are older, usually have renal failure, had just had an MI. They usually have JVD. Myocarditis is in younger male patients who just had a viral infection. We saw this in COVID-19 during the pandemic as well. It is inflammation of the heart itself and not the pericardium, so do not get this confused with pericarditis. These patients will have normal renal function, no JVD. They'll have shortness of breath like the pericarditis patients. They'll also have fever. ESR and CRP will be elevated, and there should be some kind of virus in the recent past, like mononucleosis, for example, with Epstein-Barr virus and cytomegalovirus. They may have an S3 gallop in the heartbeat. Infectious endocarditis, or IE, is a bacterial infection of the heart valves, usually by Staph aureus. IV drug users are the most common patients with this condition, but you can see it in a patient with recent pacemaker implantations or patients with recent long dental procedures. The bacteria makes a vegetation on the heart valve growing like it would on a petri dish. The valve begins to have movement issues because of the infection, and tiny pieces of bacteria are flung off of the valve as it moves, and these bacterial emboli make their way across the body, forming new abscesses. The bacterial emboli will cause splinter hemorrhages, Janeway lesions, Roth spots, Osler's nodes, and other interesting manifestations of this infection. Lung abscess can also come about from infective endocarditis. Now to congestive heart failure, one of the complications of MI. Normal left ventricular ejection fraction is about 60 to 70%. Less than 40% is left-sided heart failure. The most common heart failure is left-sided heart failure, also known as primary pump failure. The most common cause of left-sided heart failure is ischemic cardiomyopathy, which is heart failure due to myocardial infarction. This is why we fight to save heart muscle to prevent heart failure and death. You need to know these cardiodynamic definitions to understand CHF. Preload is the amount of blood the heart can take in. Afterload is the resistance the heart must work against to get the blood out. For the left ventricle, this is the systemic blood pressure, or peripheral vascular resistance. For the right ventricle, this is the pulmonary blood pressure, or the pulmonary vascular resistance. Contractility is the force of contraction or how well the cardiac muscle contracts with each beat. If we can increase contractility, then we can increase cardiac output and stroke volume. Decreases in contractility do the opposite. Ejection fraction is how much blood is pushed out into the body from the heart with each contraction. Cardiac output is the amount of blood pumped by the left ventricle per minute. Stroke volume is the volume of blood pumped out of the left ventricle during each cardiac contraction. We can calculate cardiac output if we have the heart rate and stroke volume using the equation CO equals HR times SV. Cardiac output and stroke volume will increase with increasing preload to a point, and that point is when the right ventricle cannot handle any more volume, or the maximum ventricular diastolic volume is reached. And this is seen in the first graph on the right. If the heart muscle is weakened, then the CO and SV will not increase as fast with increasing preload as seen in the second graph. Lastly, this graph shows CO and SV will decrease with increasing afterload, or the peripheral vascular resistance. This is true for both left and right ventricles. So increasing preload increases SV and CO to a point, but afterload will decrease CO and SV as it increases. If the heart muscle is damaged, then this increase in CO and SV from increasing preload will be less and much slower. Now let's compare left versus right side heart failures. This is the most common you will see. These are both heart failures from ventricular failure due to either ischemia or from increased afterload. The most common cause of left side heart failure are ischemia from MI and increased afterload from increased peripheral vascular resistance from hypertension. These patients will have shortness of breath, orthopnea, trouble breathing while laying flat, and need to prop up with pillows to sleep. Pulmonary edema on chest x-ray, cough, which is dry and persistent, paroxysmal nocturnal dyspnea, which means they get shortness of breath when laying down to sleep and may have night terrors and that wake them up, shorter breath, and also have to sleep in chairs. And they get confused due to decreased perfusion in the brain. Right side heart failure mostly comes from left side heart failure. As over time, the left side of the heart will cause the right side to work harder against increased pulmonary vascular resistance, as the left failure causes fluid buildup in the lungs. The left side failure will also cause some increase in the preload on the right side, adding to more stress on the right. The right side then fails, causing increased preload symptoms. You can have right side heart failure by itself with pulmonary hypertension, cor pulmonale, from long-term COPD or emphysema and recurrent pulmonary emboli. All these conditions will cause increased pulmonary vascular resistance and cause right side heart failure due to increasing afterload on the right ventricle. These patients are more prone to are much more profound in their symptoms. They'll be very short of breath. They'll have some cough too, but not as much as left side heart failure. Hepatosplenomegaly along with ascites is very common. They'll have pleural effusions on chest x-ray. Leg edema can be mild in left side heart failure, but in right side heart failure, it's very apparent with pitting edema, meaning when you press your finger against their leg, it leaves a pit or indentation in the tissue. The edema will also be well above the knee, and this is why we measure how high edema is in patients when they have leg edema. If they are bedbound, then it will be sacral or low back edema. Patients with right-sided heart failure will have measurable JVD or jugular venous distension. Many patients will have biventricular failure and have both sets of these symptoms. For the exam, you'll need to know the order to measure JVD if the patient has distension, or just JVP if they do not. It is the same method. You can do this to measure the pressure in the right jugular veins at any given time. Knowing the degree of JVD in a right-sided heart failure can tell you how bad an exacerbation they currently are in. These are less commonly used terms, but high-output heart failure is from being overworked, like the shunting of blood due to a fistula or hyperthyroidism causing a tachycardia or a severe anemia. This leads to a heart failing from becoming hypertrophied and then atrophied, like when the ventricles must fight against increased afterload over a long period of time. Low output heart failure is much like left side heart failure, as it is a failure of the pump itself, usually from an MI, High output heart failure is rare, while low output heart failure, as we saw, right versus left, is very common. You can have low output heart failure from a lack of preload as well if you have a blockage in the venous system preventing blood returning from the legs to the heart. You may also hear about systolic and diastolic heart failure in your healthcare career. Systolic heart failure is basically left side heart failure or low output heart failure. Diastolic heart failure is much more like right side heart failure, but instead of the right side being a poor pump, it's more due to difficulty of the heart to relax and feel fully, and it is a stiff heart. So the preload is very low in the left side. These heart failures can be seen in long-term hypertensive patients and patients who have developed hypertrophy and then atrophy of the left ventricle. Depending on what stage they are in, either hypertrophy or atrophy will determine which type of heart failure they currently have. What is the difference between acute and chronic heart failure? It's the same as in any disease that is acute or chronic. Is it new or old is the key question. Look at the diagram comparing acute and chronic heart failure. The main deviation between the two is the history component. If the patient has a history of heart failure, then it is chronic. If they do not have this, it is acute. Acute heart failure usually is post-MI or cardiac arrest or some type of cardiogenic shock. Chronic heart failure is an exacerbation of known heart failure, usually from medication noncompliance or taking in too much sodium. The workup for heart failure after a careful history and physical examination is to get a chest x-ray, echocardiogram, and labs. Echocardiogram or ultrasound of the heart can tell you if there is decreased left ventricular ejection fraction and thus left-sided heart failure. It can also assess for any valvular abnormalities that may be causing the heart failure. We can also see diastolic dysfunction here. Labs done for CHF include CBC or complete blood count, CMP or comprehensive metabolic panel looking at kidney function and electrolytes as well as liver function testing. Checking a BNP or pro-BNP, this is a brain natriuretic peptide. It is shown in several studies that increased BNP correlates with a CHF exacerbation. If BNP is increased in a patient with both CHF and COPD, then it's likely the CHF that is causing the symptoms of the shortness of breath. However, BNP is elevated in kidney failure as is eliminated by the kidneys, and it is elevated with pulmonary hypertension, and this can throw off the study. There's also an increase of BNP during a PE or pulmonary embolism. Here are measurements of cardiac work and hemodynamic stability. In bold are the ones you need to know for the exam. We can measure many of these in different ways. Pulmonary artery pressure and wedge pressure are done using a Swan Ganz catheter. We do not do this very often anymore as it's been shown to cause harm to critically ill patients. CVP or central venous pressure can be measured with a jugular venous line. Normal is about 1 to 5 millimeters of mercury. Normal cardiac output in males is at least 5 liters per minute. A left ventricular ejection fraction lower than 40% indicates left-sided heart failure. You need to know these two classifications of heart failure for the exam. This table compares the two classifications together. Notice ACC has an at-risk while NYHA does not. You can pause this lecture to study this table or come back as many times as you like. How do we treat CHF patients? That depends on the type of CHF and their symptoms or stage of disease. For those with reduced left ventricular function, ACE inhibitors and angiotensin receptor blockers or ARBs have been shown to increase the left ventricular ejection fraction over time, and using both has shown a benefit as well. Beta blockers are also important in helping these patients. Good cardiac rehabilitation is also helpful, as well as patient education on reducing the sodium and fluid intake. Monitoring the patient's labs with electrolyte studies and looking at the kidney function tests like BUN and creatinine are important, as the ACE inhibitors, ARBs, and diuretics will affect kidney function and electrolyte balances. Measuring the patient's weight daily is also helpful, as it will show if they may be going into an exacerbation of their CHF with fluid and volume overload. This ends the lecture. Maybe it's time to go for a walk.